Good morning, everyone. It's my pleasure to welcome you all to Day 4 of International Expert Talk Series 2025 with the theme Shaping Tomorrow's Pharmacists, International Best Practices and Emerging Trends. Organized by the Department of Pharmacy Practice and Pharmacology, Excel College of Pharmacy. Today's Expert Talk is on the topic Geriatric Pharmacy Practice. The session on Geriatric Pharmacy Practice is designed to highlight the vital role of pharmacists in improving medication safety and therapeutic outcomes among older adults. With the rising elderly population, pharmacists plays a crucial role in addressing challenges such as polypharmacy, adverse drug reaction, and age-related physiological changes that affect drug therapy. By the end of the session, participants will gain a deeper understanding of how geriatric pharmacy practice can enhance quality of care, promote rational drug use, and improve overall health outcomes in the aging population. It is now my privilege to invite Professor Dr. M. Rangapriya, Organizing Secretary, to deliver the welcome address. Ma'am, please.
Thank you, Mr. Bhagawan, for inviting me for delivering the welcome note on this prestigious platform of International Expertise Talk Series, Shaping Tomorrow's Pharmacists, International Best Practices and Emerging Trends. Good morning, everyone. I'm really honored to welcome our distinguished speaker of today's session, Mr. Ganesh Pandian, Clinical Pharmacy and Pharmacy Practice Unit from AIMST University, Malaysia. He is going to deliver his talk on geriatric pharmacy practice. I heartily welcome you, sir, on behalf of the entire organizing team, the management, principal, and organizing secretaries, organizing committee members, as well as our students and participants to this esteemed sessions. Welcome you, sir. Once again, I extend my hearty welcome to all the delegates, eminent professors, scientific community, student folks, and other delegates who have gathered here on this great morning to hear Mr. Ganesh Pandian, our special guest of today's session, who is going to deliver this speech on geriatric pharmacy practice, a very, very important thing because vulnerable population are exceeding today's scenario in the healthcare team, and it is quite challenging to face those vulnerable populations and deliver the healthcare to them. So this topic is driving today's session by Mr. Ganesh Pandey. Once again, I heartily welcome all the delegates, professors, and the distinguished speaker also today on behalf of the entire management, principal, faculty members, and the organizing committee of Excel College of Pharmacy. Welcome you all. Thank you.
Thank you, ma'am. We will begin the introductory remarks of our esteemed speaker, presented by Mrs. S. Asha, Department of Pharmacy Practice. I now invite Mrs. Asha to introduce our distinguished speaker, Dr. Ganesh Pandian Balasubramanian, sir.
Good morning, everyone. It's my great pleasure to introduce our expected speaker for today's session, Mr. Ganesh Pandian. Mr. Ganesh is an assistant professor of clinical pharmacy and pharmacy practice at AIMST University in Malaysia. With over 14 years of the experience in academics and research, his expertise is deeply rooted in geriatric pharmacy and clinical pharmacy practice, and has guided numerous student research projects in these areas. He runs active researches in multiple publications in reputable international journals and frequent speaker at global conferences. We are truly happy to have such as experienced, knowledgeable professionals with us today share his insight. Please join me in a warm welcome to Mr. Ganesh Pandian. Thank you.
Let us now commence the expert talk session. Now the session is up to you, sir. Sir, please.
Okay, thank you. Am I audible?
Yes, sir.
Okay, please give me a minute to share my slide.
Yes, sir, it's visible.
And I believe it is in the full screen mode now.
Yes, sir.
Okay, okay. Thank you. Thank you. Before I start my session, I would like to thank the management of Excel College of Pharmacy and also for inviting me to deliver a talk. And thanks to my friend, old friend, Mr. Prakasham. So after a long time, we had a nice chat. So thanks for bringing me into your college. So thank you, sir. So I record my appreciation and thanks for the organizing committee. So everyone who are actively involved in delivering in this webinar a successful manner. Okay, so with that, I think my introduction has been done. So basically, I'm from pharmacy background. So I have completed my MPharm and then I was work practice. I'm teaching the pharmacy courses like BPharm and PharmD, and later I moved on to Malaysia. So it's been 11 years now. So here in Malaysia. So I would like to start my session with the experience or the exposure what I have been uh, came or gone through is before I join abroad. I start practicing abroad. So like the normal course, the geriatric pharmacy is like usually we will be having in masters or in MPharm or in the PharmD degree. Like in clinical pharmacy, there will be one topic like prescribing patterns in geriatric, prescribing patterns in pediatric, and just a topic. Maybe it's a subtopic. But later when I moved on, right? So here, like even Malaysia also is not so developed in geriatric pharmacy, but they are, I would say like it is very well established for the geriatric pharmacy. So in pharmacy curriculum, the geriatric pharmacy was been there. So I was involved in the teaching for the geriatric pharmacy. Then later, it it is more important. I realized like it is more important because basically, I believe like all the participants who are here for this today's webinar is having a pharmacy background and also more specifically for the clinical pharmacy background. So the basic principle for delivering or for providing any care is like pharmaceutical care, like we care the patients or any individuals pharmaceutically to achieve outcome. But in that population, there are certain people or certain group of people where have not been considered, right? Maybe I would say like the geriatric population, maybe the pediatric population, there were a little emphasis have been realized a little earlier. But for geriatric population, we treated or they have been treated like an adult population only together. But actually speaking, they are not adults. They cannot be categorized under adult because they are completely different. That geriatric population, where according to the WHO, they say like it is more than the 65 years old. So it is completely different. Like they are being categorized as a geriatric population, where they will be having a different kind of body structure. Their physiology is different, and also the drug what we give for the adult population, it cannot work for the geriatric population. So which means like they have not been treated properly. And even there are many countries even now, as of now, like even they have not emphasizing more on the geriatric population. But unfortunately, if you look into the statistics of every countries or every data what is being presented now, every country is been moving or being considered as an aging nation. It's not the nation is getting old, but the old population, the geriatric population, the percentage of the geriatric population who have been present in that country is been getting more, right? So which emphasize more on the requirement or the care to be given for a geriatric population in specific, because they are very fragile people. They are very, very fragile people. Like just like how we treat a pediatric population, geriatric population also is very, very fragile. Okay, pediatric population, maybe at least you can expect some compliance from them, like you can force them, you can cheat them to give the medications in administration. But geriatric population, they have emotions, they have all, they respond you back, like everything. So even any one particular criteria is not being addressed, so it is going to be affect the whole process, right? So even that is a major difficulty in having the geriatric population under a compliance, which means like to make them to complain to the treatment or any therapeutic outcome what we have been expecting for. So that brings like many nations now they are focusing on the geriatric pharmacotherapy or the geriatric pharmacy, and also like there are certain departments have been established like not as a pharmacy altogether, like geriatric pharmacy they focus more on the geriatric population, their needs, their care, how it can be working on that, how they can be treated for, and this requires not only the medications, right? Because later in the slides, we will be seeing about, right, the different parameters or the different aspects which will be influencing on the geriatric pharmacotherapy or in the geriatric treatment. Okay, so that I will be discussing. So with that, maybe I believe like this is our campus, like it is our beautiful campus located in the northern region of the Malaysia. So we have a direct link for what to say, like to our Tamil Nadu as well, right? Because the Chola Kingdom, when they reached Malaysia, they reached just 2 kilometers away from this place. We have one place known as the Bujang Valley. So there only they reached here. So it is like directly linked with Malaysian, sorry, the Indian community and also like the Tamil people, right? So just an information. I thought it would be helpful. So this is our campus. And today with this session, like the learning outcomes is going to be like by the end of this session, the participants, I believe like they would be able to understand the need for the geriatric care, and they would be able to understand the physiological changes which will be occurring in with the aging, and able to explain what geriatric syndrome is, and to know about like what is to what is about the PIMS, which is also known as the potentially inappropriate medications, and also the polypharmacy, which plays a major role in deciding the geriatric pharmacotherapy or the geriatric treatment. So then to know what are the roles of pharmacist in the geriatric care provision, right? So what could be done in future, like that can be done, right? So this is the learning outcome. I believe like I can deliver my content which can be able for all, right? So here, before I proceed, like there is a data, right? Any geriatric talk you go for or any lecture you go for, I think this would be the very first slide that you would be having for, right? The life expectancy at birth by the WHO, which means when right now, right, when someone is born, how long they are expected to live, right? With the current situation, current scenario. If you can see, on 1700s, right? So it was around 30 years only. The people were expected to live only until 30 years and 40 years only, right? So this is according to the statistics, according to the World Health Organization. It's not only for India, it's for the world, right? So they have given in that range. Where if you can see like from 19th century onwards, like it is slightly increasing, and it is now currently the latest data from the WHO is on the 2023 published one. So now our Asian population are expected to live around 70 years, right, by birth. Where this life expectancy will be changing or will be varying in case if we check on the life expectancy by 60 or when they reach that geriatric age, right? That also will be differing, and in that it will be differing like to male and to female. Usually a female are expected to live higher than live longer than the male population, right? So these are all some of the statistics where it has been given. So here now you see every country or every continent, they are increasing with the aging population, which means like the total number of population which have the geriatric population is getting higher and higher. But the services or the facilities which has been available for treating or for meeting the demand of the geriatric population, if it is sufficient, means like maybe certain countries like America and Canada, they might be having that facilities, but other countries, they are not even sufficient enough, right? So which means like still there are more emphasis is needed for the geriatric pharmacotherapy or the geriatric treatment, because this geriatric treatment where it includes like the geriatric population, they will be having many complications, many diseases, and also like their lifestyle modifications, their problems, their personal, everything will come together, which will be affecting the treatment which we will be providing for the population, right? So it is one of the things where if you look into the data for India, so as of 2021, like it is ranging between 66.9 to 67.8 years, right? So the one reason for this increased number of increased life expectancy is due to the facilities what we have, due to the lifestyles what we have, and also like due to the treatment or also due to the medical interventions which has been available now. So that have increased, right? So the life or the longevity of any individual, as the longevity of any individual is increasing, it it further needs like the care or the facility also it have to be given. I think every one of us we know, right? The senior citizens, every country, they will be having some special discounts. They will be having some special what kind of not discounts, like they will be having separate considerations, or the concessions will be there, right? This have been a method which have been adopted by every country, or every country, like to ensure that the geriatric population is not left out, right? Their facilities or the adequate facilities which is required for them is being provided adequately. So that is how they will be providing, right? If a government can do for the well-being of the geriatric, being a pharmacy professional, so and also being involved in the healthcare profession, we have to provide an individualized treatment care for the geriatric pharmacotherapy for the geriatric populations, right? They cannot be considered like an adult population. So they have to be treated separately, and their considerations is separately required. So as aging, what we say, like every one of us, we know like we are aging minute to minute, day to day, weeks and year. It cannot be reversible, right? It cannot be reversible. So we are aging, where this is a process which is inevitable, where we cannot reverse it back. And also likewise, the organ function also, it is decreasing, right? Maybe our knowledge, our wisdom, or any individual's knowledge, wisdom, or their expertise is maybe getting increased. But in our body, like the organ function will be decreasing, right? Not completely low. Maybe compared to the previous year, it may be reducing to a further extent, right? So this not necessarily it should happen only for the deceased individual. No, this can happen for an individual, those who are leading a good lifestyle, they have a better living status. Even then also this decline in the organ function will be occurring, right? So we cannot deny, or we cannot decline, or we cannot avoid that one also. So this is unavoidable thing, so it is happening. So in addition to this one, like if we have poor lifestyle choices, where maybe that will be speeding up the process of the organ functioning decline. So that will be separately. Where the point to be noted here is like whether we follow the practices, healthy practices or not, our organ function has been declining. So as per the available data, or available evidences, they say like as we age, once every 10 years, our kidney function will be depleting to certain percentage, right? So this is normal. So our methods, our adaptations have to be differently fixed for the particular choices, right? So that is what it is needed. So this aging process, it's not going to show or show disease progression, or it is not showing functional decline immediately in the first point itself. No, there will be the reduced capacity of the functioning of the organ, right? But later this homeostasis cannot be maintained under stress, where this will lead to the illnesses and injury. So this will be occurring. It is a normal process. We cannot do anything on that, right? Out of this whole organ system, there is a particular three organ system is known as the weakest link system, or weakest links, where the point is like any harm or any small alterations occur to that particular system, it is going to cause a huge trouble. for the geriatric population especially, right? So that is why they call it as a weakest link system. So they are most vulnerable for the geriatric population, and those three systems are the cardiovascular, renal, and the central nervous system, right? So any one problem occurs like that, before we sort out that problem or that issue, it is going to be leading with the further injuries, which may be sometimes reversible if we are lucky enough, and most of the times it may not be reversible. If you look into the geriatric population also, where they may be okay, they may be performing their all the activities normally, even though they are 70 or 75, they will be performing normally without anything. But just inclusion of a drug which affect the renal function, that is sufficient to take their life, right? So maybe if the same thing happen, the drug-induced nephrotoxicity happen for an adult population, maybe it may be reversible. Maybe we can try to get back the patient to the normal condition. Maybe there are chances, but for geriatric populations, it is not at all a possible way, right? So the physiological changes which occur for the geriatric population is like the here it is represented in the pictorial way, right? If you see like the weakest link system, the cardiovascular, the reduced exercise tolerance, and also like the hypotension will be there, then increased risk of the atrial fibrillation will be there, and as they age, the heart rate will be reduced, and also like they will be the elasticity will be reduced. And also when we look into the kidney function or the renal function, the renal blood flow itself will be reduced, which will be further, it will be affecting in the glomerular filtration rate, and also like in the clearance also it will be affecting, right? So which will be leading to the nephrotoxicity. But there may be some parameters which may not be affecting the which may not be altered because of the aging also, like for example the serum creatinine, it is not going to be affected, right? The levels is going to be the normal, but the GFR will be changed for the geriatric population, right? So here, if you look into this, right, there are detailed information is available. Like basically, our body function as we age, it will be deteriorating, and also like the body function also will be declining, right? So every systems, right? So you can see there are many texts, many evidences which are being available. So there you can see. So in that, most importantly, we need to look after the weakest link system, especially the cardiovascular, renal, and the CNS. So this have to be mainly considered for the treatment or for providing for a treatment for geriatric population. And nevertheless, we cannot ignore the other body functions or the body functions also, like it have to be also taken care of equally, right? So this will further lead the physiological changes which will be happening for the which will be occurring due to the aging. It will be happening, or it will be leading to the changes in the pharmacokinetics and also the pharmacodynamics, which is the drug-related properties, right? For the pharmacokinetic changes, you can see the gastrointestinal motility will be decreased, where this will be affecting the absorption rate, but not the extent of the drug absorption. The drug absorption, how it is going to be absorbed, it will not be affected. But because of the motility have decreased, but the rate of absorption will be decreased. Where consider if we are applying the same principle which is for the adult to the geriatric, means like here the absorption is not the same, right? The gastric pH will be increased, where this will not be causing any significant changes in the drug absorption, and the renal function will be decreased, which place or which requires more focus on the drugs which are eliminated renally. So because all the drugs are eliminated renally, their kidney function is not so normal, right? I'm not saying like they have the renal failure. It is not up to the original functioning. So it will be reduced. So that will leads to injury, kidney injury, or the nephrotoxicity. So this may be further deteriorating, right? So the reduced elimination will be there. So which plays a major role in considering the drugs which have been eliminated renally. And the serum albumin will be decreasing, where the decreased protein binding will be leading to the increased fraction of the drug, free fraction of the drug. And phase 1 hepatic metabolism will be decreased, and also the body to fat lean muscle ratio will be increased and the total body water will be decreased, right? Where this decrease in the total body water will be mainly playing a role in the volume of distribution which is available for the water soluble drugs, right? So once the volume of distribution is decreased, so the drug properties is not the same, right? So pharmacokinetically, these are all the changes which will be occurring, some of the changes which will be occurring, and also like pharmacodynamic changes which will be occurring in the drug therapy is this sensitivity to the beta receptor will be decreased, where the beta blockers, use of the beta blockers may not be more appropriate for a geriatric patients, right? So, which means even though the patient can, it can be a drug of choice for the patient, but for geriatric patients, it may not be because the response it has been decreased for the receptor sensitivity, so it may not provide the required responses. And the baroreceptor sensitivity will be decreased, which will be causing a greater risk of the orthostatic hypotension, where if later we will be seeing about the geriatric giants also. In the geriatric giants, one of the important parameter which decides the geriatric or the old people's life is falls, or also known as the instability or the gait instability, right? So this is nothing, just normally they can walk normally, they can proceed, lead their life normally, but all of a sudden they just fall down without any reason, without any hindrances or without any obstacles, they just fall down. So this can happen because of their change in the physiology, right? So, and also like this drugs which are affecting this sensitivity will be causing to the orthostatic hypotension also. So the drugs which induce the orthostatic hypotension have to be carefully given for the patients, because without the drug itself, when the patients or when the not sorry, I cannot call them as a patients, when the geriatric individual, they're just walking normally, they can fall down, no any reasons, they just fall down, right? So this may complicate their treatments and complicate their livelihood in future also. Okay, so the response to the benzodiazepines and the opioid analgesics will be increased, where it increases the risk of the adverse effects also, right? Which requires for the changing or the alteration in the doses also. Okay, so this is the pharmacokinetic and pharmacodynamic changes which may be occurring for the geriatric population, where there are some thing in addition also. Where the point I am emphasizing is we cannot apply the adult population's principle or adult population's guidelines to the geriatric population. It have to be different, right? So because it's not the same, not here and there are some changes. No, everything has been changing. Okay, so coming to the another part, the challenges in diagnosing for a geriatric individual, where if a diagnosis is not made correctly, then definitely we are going to have a difficulty, right? Because the treatment is not going to be the same, where this further it may lead or it may complicate the process or the living of the individual, right? So here some of the conditions have been included, like mistaking the pure aging for the disease, right? A physician cannot, or even as a pharmacist, when we look after a geriatric person, we simply cannot deny all the factors or all the parameters just considering like they are aging, right? So if the patient is having a difficulty in retrieving the information, straight away we cannot say like, you are a old person, 70 years old, so you may be having dementia. Okay, so that may not be correct also. So it cannot, the diagnosis, there should not be any changes or there should not be any confusion should be occur, right? So here we can apply some of the assessment methods to know whether they are really having the dementia or not, so that we can provide them the treatment, right? Straight away we cannot judge the patient like because of their age, like they you have dementia. No. And the other example is the mistaking the disease for the aging, doing the other vice versa. So if there is a disease, but we say like, no, it is an age-related thing, right? So that is also not correct. It have to be diagnosed properly. And we ignore the increased risk of the adverse drug effects on the weak link system, which will be causing the illnesses. The treatment when we are providing the treatment to the individual, so we have to know whether that particular drug is going to affect on their body function or not. Just like how what I mentioned is like any you go for the aminoglycoside antibiotic means like definitely you have to know this is going to cause a nephrotoxicity for an adult population, but for the geriatric population, definitely it is going to cause some serious illness for the renal function of that individual, which means like we should be very careful in giving them the medications, right? We cannot go or risk the patient for getting the outcomes, right? So we forgot that the elderly have often multiple underlying disorders where being a old person or aged person, so definitely there will be some underlying disorders will be there. So we need to ensure whether that have any link to the treatment what we are going to give or not, right? So this is we are speaking about the physiologically, right? Their body functionally, but there is another part also like we need to pay a more attention for like the geriatric giants, which encompasses the problems what they can face in their normal living, right? In the normal living. So in the geriatric giants, there are five eyes, which known as the incontinence. Incontinence is a condition where they cannot hold up their urine or feces, so they just um, relieve the they couldn't control the urine and feces, right? So this and instability, which refers to the gait instability, they cannot they may be they are completely at the risk of falling down. Okay, the intellectual impairment, like the decrease in their cognitive levels, right? So they may be losing their intelligence, right? So in further, if we can know about this intelligence, there are two types of intelligence known as the crystallized intelligence and the fluid intelligence, right? So in those two, the crystallized intelligence, there will not be any changes, right? So they will be having some of the skills that they have acquired. For example, driving. On a normal age, when they have been driving the car or motorcycle, whatever it is, right? Even they are aged, they don't have any difficulty in driving that. But that is considered as a crystallized intelligence, right? The skill what they have. But fluid intelligence is the critical thinking and the problem solving. Those kind of issues will be considered as a fluid intelligence, like they need to know like what is the things to be applied, and also like certain informations they may be forgetting, right? It cannot stand forever. So the fluid intelligence will be changing for sure. Okay. And immobility is inefficiency to move around, like this will be discussing on the functional disability. The functional disability is also one of the major parameter which decides on the medication treatment for the geriatric population, because if they cannot move around, we need to have a supportive system for that individual, right? So and iatrogenicity, any problems which causes by itself, by itself, right? So the iatrogenic reasons. So this is altogether known as the geriatric giants, right? So here it can be related to the socio-economics of the geriatric population, where the socio-economics is maybe considering the physiological changes, maybe we maybe plan a better treatment for a patient considering his physiology, his pharmacokinetic and the pharmacodynamic parameters. But socio-economics, do we need to consider as a pharmacist, right? So for example, if they are having immobility, they cannot move around, not necessarily inside the home itself, like they cannot move around. So do that affect the treatment what we have been providing for the patient? If in that question, for that question, the answer would be definitely yes. Because if that person is unable to move from one place to another place, even inside the home, they cannot live their life normally, which means like they need a support, right? So at that time, if we are giving them the treatment which have to be taken or which have to be undergone by himself only, there is no any other support system. So which means it will be leading to the non-compliance only. Because consider, for refilling the prescriptions or for getting the medications, they need to visit at least the pharmacy. They need to visit the doctor, right? So they need to move around. But if they are having immobility, they cannot move around, they don't go for a doctor, they don't go and get their medications taken. So this will be affecting their their drug taking, being compliant to the treatment, right? Even though they want to be compliant to the treatment, they are forced to not having an access to get the medications prescribed or delivered, right? Normally, the alternatives or what are the other methods to overcome this one, we can see later, right? So it can be seen later also. The instability, if the person cannot walk normally, how he is going to be confidently come to a healthcare facility to get the medications, right? So you remember, you just think like when we can walk, we know like, yeah, we are going to walk normally, so we are not going to fall down anyway, so we confidently we walk. Where for geriatric individuals, that will not be the condition. Like the confidence will be shattered at the very first moment they fall down, right? So that also will be leading to some of what to say it will be leading to the some fractured hips bones, right? So because of their low bone mineral density, it will be leading to the severe fractures also. So this all together, it will be continuing. It will be contributing for the daily activity of the daily living, and also the instrumental activities of the daily living, which decides whether that person can lead their life or live their life alone, individually, or they need to be supported by any other measures. Like, uh, for example, if they cannot go and take the medication, means like they can use an other source, right? They can ask their friends or their family members, or even they can ask, if no one to take care of them, means like they can ask some services where they deliver the medications, right? So even the pharmacists, they are being helpful in delivering the medications at doorstep, so they can deliver the medications for the individuals also, right? So this is how they can, it can be sorted out. Okay, so this, in addition to the physiology and also the pharmacokinetic and the pharmacodynamic properties or the changes which occur for the geriatric population, we need to consider the geriatric giants also while optimizing or while providing a treatment. Okay, if not, means simply we say like pharmacokinetic and pharmacodynamic properties all have been taken care of, but the treatment have been given, the prescription, the medication have been prescribed for the patient, but he is unable to walk around to go and get the medication, which means like they will not be compliant to the treatment, which will be further affecting on achieving the therapeutic outcome of the patient. Okay, so here is why we are failing to have the evidences, or why we are failing to have the treatment, especially for the geriatric pharmacy, is the age-related changes, as we have discussed before. Yeah, it adds a complexity to the drug treatment for the individuals. But in addition to this one, the limited clinical data which has been available, right? So as you are aware about, like the clinical trials cannot be conducted for the vulnerable population. Unfortunately, the geriatric population also comes into this range. So the geriatric population will be known as vulnerable population, and they cannot be conducted with the clinical trials as easily. So there are limited data available for this one, and also like the increased adverse events which is occurring due to the complex drug regimens and also the pharmaceutical physiological changes, right? So this adds the complexity to the drug treatment. Okay, so the reason for the drug-related problems in the elderly is we have to understand the factors which will be leading to the drug-related drug-related problems, which will be the it have to be safe for prescribing. When we are prescribing a treatment for the geriatric populations, it have to be um, excuse me, am I audible? I hear some sound.
Sir, audible, sir.
Okay, thank you. So because I couldn't see the other slides, so I couldn't know. Okay, so the drug-related problems, like we need to understand the factors which will be leading to the drug-related problems, where it is really important for the safe prescription of the elderly population, right? So these are all the problems that we are going to discuss. I'll be discussing now. So the first one is the drug-disease interaction, where any drugs which we will be giving for treating one condition, it can worsen another condition. Basically, it is nothing but I'm speaking about the prescribing cascade, right? So basically, we will be thinking like we can give a treatment for a particular drug, but without considering the geriatric parameters that cause another condition, and you add a medication for that one. So it is going to add increasing, right? So this event, chain of event is known as the prescribing cascade, where, for example, you can see in the case one, when we are giving the antipsychotics for geriatric patients, this antipsychotics will be mimicking the Parkinson's symptoms also, right? So when the patient is mimicking that symptoms because of the antipsychotics, and without considering this one, when a treatment for Parkinson's symptoms have been started, then that is a misdiagnosis and also a wrong treatment given for the patient. Okay, so that antiparkinsonian drug will cause orthostatic hypotension or the delirium. Further, it is causing one event and one after another, right? If we start addressing for every event, it is going to be difficult. And case two, you can see when we give the cholinesterase inhibitors such as the donepezil for the dementia, when the patient is undergoing treatment for the dementia, when we give the donepezil, it will cause the diarrhea or the urinary incontinence, right? So for urinary incontinence, this socioeconomically also it will be affecting, like in taking the drugs. Like if they take the drugs and they couldn't control their urine and the feces, means like they may not feel so nice, so they may be stopping the medications. And if they are taking also, in order to address this incontinence, we add an anticholinergics. Then again, anticholinergics is completely not suitable for a geriatric population, right? So it have much drug interactions and it have the much adverse effects, right? So like this, we, without considering the actual parameters, if we keep on adding one after another drug, and even if the diagnosis is also not so correct for the geriatric population, then definitely it is going to lead for the prescribing cascade, right? So here you need to know any drugs which is not required or which is not suitable for the patients. We can categorize it as a potentially inappropriate medications, right? Shortly known as the PIMS, right? So there are list of medications which have been available, list of guidelines which is available to know like what are the potentially inappropriate medications. The one among that guideline is the American Geriatric Society's Beers criteria, shortly known as AGS Beers criteria. They have given extensively list of drugs which will be having or which will be list of drugs which is not suitable for a geriatric population, right? So it is better to refer to that guideline before we start with any treatment, right? And there are other sort of the tools are also available, like start and stop guidelines. So we can use that in order to provide for the treatment for the geriatric individual. Okay, so now this is the drug-drug interactions, where usually among the geriatric populations, they are expected to consume more herbal supplements or even other vitamin supplements, or even they will be consuming the household spices and all the household complementary medicines. They say like their belief, they want to just follow this one. It's okay, but when it has been occurring together with the when it has been interacting together with the medications, right? When the medication has been prescribed for the geriatric population, you don't consider about their other medications. Let it be the OTCs, and let it be the herbal supplements, or even any other habits, the social habits that they have been following. So it is going to interact, which will be also a difficult and situation for the geriatric population, right? So usually, like the common spices like the ginger, garlic, ashwagandha, like even now the common advertisements, we can see ashwagandha, you take it for your body rejuvenation and like that, it is there. So if they are consuming, and us from the healthcare team side, we are prescribing a medication for the geriatric population, we don't consider about their other supplements, and we have given any medications. If it interacts, it increases the risk for the polypharmacy, and also to the it will affect the well-being of the geriatric individuals, right? So at every time, every point, we need to ask like whether they are taking any other medications. Usually they don't even consider like those are all the supplements when they are taking, right? Ginger, a little amount when we cook our food, that's fine. But ginger, some people they crush the ginger and they used to take the paste, and like their knowledge. So it may have to be considered. It may have to be taken into account for, right? So coming for this potentially inappropriate medications, I happen to conduct a research among the community pharmacists who are working in the Malaysia. So in this state. So here, our study finding this article was published in somewhere in 2018, I think so. So here in this article, in this study, we approached the community pharmacists to know about the potentially inappropriate medications. Where to our knowledge or to our surprise, every community pharmacist who were practicing, they were having an awareness like about the potentially inappropriate medications, especially for the geriatric population. But further, when I delineated, the problem is like they don't know like which resource to be using. For example, the source or the tool to know like what are the inappropriate medications. They are not aware about the AGS Beers criteria, and also like they are not having much thing, but they are aware about like the medications may not be suitable for the geriatric individuals, right? So which means like it's a contradicting, you may know. But here, the point to be explored, the what we have further, if you can read that article, means like you may be having a complete idea also. Here, some of the faculties, like some of the universities which are offering the pharmacy courses in Malaysia, they are not having the geriatric pharmacy as a course. And even if they have as a course also means they will be having as an elective paper only. Not everyone will be taking the geriatric pharmacy course. Like those who interested only, they will be taking the geriatric pharmacy course. Those who have not taken the geriatric pharmacy course, like they were not aware about this one, right? So later, what we have concluded in this one is to include the curriculum of the geriatric pharmacy in as a core paper, right? So which means like they are ready to adapt for the situation. They know the seriousness of the potentially inappropriate medications, but how to approach it properly, that they are not aware about, right? So this was conducted 2016 to 17. We have conducted the research, and I think it was published in 2018. So yeah, and the next problem or the drug-related problem, what we can what you can know is inadequate monitoring. When usually when we are been providing a treatment for a patient, we have to monitor completely, where for geriatric, we need to document all the indications, right? So all the indications have to be documented. Then later only you need to review it, whether it is because of the drugs or is it because of the patient's condition. So is it an adverse effect or it is an side effect, whatever it is, like it have to be, every indication have to be noted down for a new drug when it is been starting, and keeping a current list of drugs using by the patients in the medical records. One major problem faced by the healthcare team is missing up of the information at the transition points. The transition point is nothing but, like, for example, if the patient or the geriatric individual have undergone a treatment in a particular clinic, like primary clinic, maybe sometime, and later after some time he wish or he moved to another place, or even he's not okay with the treatment given by the primary clinic. He just want to consider multi-specialty hospital, where when the multi-specialty hospital, when they enter the hospital, they just receive the patient and then they will be getting the details only, whatever details is available. But it is really important to have what are all the medications that the patient is taking, what are all the medications that the patient have been prescribed with, and what are all the medications he is taking for his comorbidities. Everything, it have to be taken for every transition points. It's not about from transferring from one hospital to another hospital. Even in the hospital, when the patient has been transferred from the one department to the another department, the information how to be shared, right? Why? Because is missing up of the information in the transition at the point of transitions have led to the what to say have led to the drug related problems. Majorly all the drug related problems which occur for the geriatric patients, especially in the hospital, is missing up of the information in the point of transition, right? So when a geriatric patient walk in, so no matter whether he is already admitted in the same hospital, he's been visiting the same hospital for many years, means like it's okay. Still, we need to ensure the information adequately for the patients. And the another problem in monitoring is to achieve the therapeutic goals and or the other responses to the new drugs, whether we have achieved the goals or not, right? So it have to be noted down and it have to be, and we need to perform the laboratory tests for the efficacy and also for knowing that adverse effects. And this reports have to be periodically reviewed, and also like even the patient is taking the medication for quite long time. So periodical review of the drugs has been more important, right? So this insufficient monitoring will be playing a role in increasing the risk of adverse effects and also the ineffectiveness. And the main focus on the inappropriate dosage or the duration of therapy is there any duplication of therapy, and also for any drug-drug interactions is there, means like we can find it out and we can sort it out, right? So the duplication of therapy, maybe the patient may be taking some medications as a OTC. They might have taken from a pharmacy, they may be taking for that. And now again, we give the same medications, means like it is going to be duplication of therapy where it is not so good for the geriatric individuals, right? So for any individuals, it's not so good, but geriatric, it is going to be the harm, it is going to be a little more harm for the patients, right? So the another problem what we face with the geriatric pharmacotherapy is inappropriate drug selection. We're selecting a drug where which is not suitable for the patient is definitely is not a good thing. And also like even if it is suitable, whether it is suitable for that individual, right? Whether for that patient, whether it has been suitable, right? So you cannot apply the adult principles over for the geriatric population, right? So it have to be considered for that. When a drug is being inappropriately used for the patient, it includes the choice of the unsuitable drug, where we know the 5 Rs, right? The right drug to the right patient at the right dose, right? So that applies for the geriatric population also. And we need to know about for any duplication of therapy, whether it's there any medications is been repeated, and failure to consider the drug interactions. Maybe for adults, maybe we may be accepting for even the mild type of the drug interactions. It's okay, we can proceed with that one. But for geriatric, we need to be little cautious about that one, right? So also, once the drug is being stopped, but or the condition have been resolved, still the drug is been continuing. So this is also a problem for the patient, right? So this another problem what we have is lack of patient adherence, where this patient adherence not only when we prescribe medications, when a medication has been prescribed to the geriatric population, it's not only whether they take that drug or not, but there are a lot of factors, as I discussed in the geriatric giants. It plays a major and the vital role in deciding whether the patient can be adhered to the treatment or not. Okay, so usually the study data, most of the study data, it is showing like half of the elderly patients do not take the drugs as directed, because usually they will be taking less than prescribed, right? So this is not intentionally, sometimes it is unintentionally also it will be occurring. Okay, so some of the parameters what we can see is geriatric giants definitely will be playing a role directly, and also the what the socio-economical issues also will be playing a role, right? So here, when we are prescribing medications, we need to consider the financial and physical constraints of the patient also. If a drug of choice is being made, but he is not able to pay for that medications, means like then definitely you can expect an non-adherence from the patient. And also for the physical constraints, whether they can move around, their functional ability is okay or not, activities of daily living and active instrumental activities of daily living, we need to really think about that, right? So in this too, out of these activities of daily living and the instrumental activities of daily living, instrumental activities of daily living is more important. Even if they cannot perform any one, they have to be seeking care of a supportive environment. Either they can be placed in a nursing home, where or they can be sent to a daycare home, or even appointing a person to take care of them, or even appointing allocating any one person to provide the care for the individual, right? It is really important, which decides the patient's adherence for this one. And the next parameter is, the next condition is the cognitive difficulties as they age. If they forgetfulness is not is cannot be considered as dementia completely, but forgetfulness is a part of the aging. So this also will be playing not for adherence, like not necessarily they may be skipping the dose, they may be taking the dose multiple time also, right? So they forgot how to take that one also. there may be some problem. And also, like in addition to this one, I think I don't know whether I have included or not the interaction what we made with the geriatric population. Another research what we have conducted. So there, what is the difficulty that they have being adhere to the treatment is majorly they say like difficulty in taking the medications in administering the medications, right? So you see a geriatric person's a old person, his hands may be shaking, and we give a container which contains the medications and they need to open it up and then they need to pour it out. Means like they just spill the medications where it is being difficult for them. This is the major concern for the geriatric population, right? One of the to be non-adherent to the treatment. And also like use of multiple drugs, whether knowingly or unknowingly, and use of the drugs that must be taken several times a day. In a day, they need to take many drugs, but they miss out. They are not interested to take. And also like lack of understanding about what a drug will do, the benefits and the harms of the drugs by taking or by not taking the drugs. So they should be able to know also. Okay. And here, in addition to this one, I can relate also like there will be certain age, certain condition where the patients they feel lonely because of their family situation or familial conditions. They feel lonely. They don't want to take the medications because they know they need to take the medication, but they intentionally skip the medications, thinking like they don't want to live further, right? So this is also one of the problem with the geriatric patients, right? So for that, some sort of counselings, some sort of motivational counseling should be playing a better role for those kind of for addressing those kind of situations, right? So here, another research what we have conducted for assessing the functional disability, right? So how they are able to move around among the older population in this state was published. So this one, the results shows like out of the study population, I think around 200 or 300 population, we have conducted this, sorry, 266 elderly populations, we have conducted this one. And out of this, around 42% of the study population have estimated to face at least one difficulty with the activities of daily living. And also 57% of the population had difficulty with instrumental activities of daily living, which means half of the population they cannot lead their life by themselves, which means like they have to be taken care of. This is related to the pharmacotherapy or in achieving a patient adherence to the population, because if they cannot perform any one activity, they need to have a supportive system. So which means like half of the population, these people are not what to say, admitted to any nursing homes or not. They are normal adults. They were just living their life at homes, at their home. Like normally they were proceeding with their life, but it has been observed in this way, which means like they have to be supported. Okay, so which plays a major role in deciding on the drug treatment for the elderly also. So next one is the overdosage. So it is easily understandable. Like we give what is required more than the patients, and here the point to be considered is like what is for adult dose also can be a overdosage for a geriatric population. So the dose titrations how to be carefully decided for the geriatric populations for that individual only. So it is really, really important. And the poor communications, as I have discussed before, like at the transition of care, like if we have not collected the information correctly, the 50% of the drug errors will be occurring, and the 20% of the adverse drug events which is occurring in the hospital is because of the communication failure at the transition of care. Just getting the information for what is the treatment, what he have been undergone before. So what is his current progress? We don't include that failure to get the medications or the list of information will leads to the drug errors, which is more than half, right? Almost 50%. Okay, so this by avoiding this one, you will be unnecessarily continuing the medications, or you will be vomiting some of the necessary medications also, right? So this requires a coordination between all the members and all the healthcare team members who are been dealing with the geriatric populations. And next one, I think this is the last one, the drug-related problems, is the under-prescribing, where thinking that overthinking about the geriatric populations, physiology, and also the socioeconomic things, we don't give any medications and we try to limit more than the required one or less than the required one. It is definitely an under-prescribing, right? So this is also a major problem which occurs with the geriatric populations, right? So thinking that we do better for the geriatric populations, we are actually harming the patients, right? If not giving medications. Okay. So, excuse me, just next. Yeah. So the drug-related problems, what we have seen so far, how it can be prevented is by adopting certain methods or certain measures. What we can do is by to optimize the better treatment for the patients. We're here for before we start any medications for the patients, what we can do is just look for whether really the drug is needed or not, which means like if there is any other alternatives is available to address that condition, please go on with that. Don't immediately start a medication for each and every symptoms that the patient has been exhibiting, right? So it is not at all nice. And also like to establish care goals, like what should be the treatment objective. So this have to be discussed with the patient. And also like mainly as a pharmacist, we need to communicate with the physician also like what is the expected outcome, because considering the risk benefit ratio for the geriatric population may not work for all the patients. Sometimes you need to risk the patient also, right? So at the time you have to discuss everything for the geriatric with the physician who is treating the patients. And please document all the informations clearly, so it can be no any informations have been missed for the for the patients. So at every transition points, it can be correctly delivered for the patients, right? So to avoid any errors. And also the process to follow this to collect the information at every transition point is known as the medication reconciliation. Okay, that I think in the next slide I will be discussing about. And assessing the age-related changes when a drug therapy is being initiated for a geriatric population. So definitely we have to assess on the age-related changes, the pharmacodynamics and the pharmacokinetic properties also have to be really taken care of for that individual to start with the medications. And to provide a safer and treatment for a geriatric population, choose for the safer alternatives if it is available, right? Like selecting an acetaminophen over NSAIDs, we can select and look for the interactions. And as the principle go, start low, go slow. Excuse me. Start with the lowest effective dose and titrate gradually based on the patient response. Like we that is how we need to really provide or titrate the dose for the individuals, right? So not the immediately like intensive treatment cannot be suitably given for the patients. You cannot start so hard and fast for the geriatric populations. Okay, to monitor the prescriptions. So look for every pharmaceutical care issues which will be arising with the treatment or with the proposed treatment. So make sure like there are no any pharmaceutical care issues has been to think, so that will solve most of the problems. And also like providing or doing the regular checkup and also like surveillance, like assessing their laboratory parameters by performing all the clinical pharmacy activities. Maybe we can help to avoid when the prescription is being given. And also like in case if the patient responds, based on the patient response, we can start or we can provide the treatment and we can adjust our treatment accordingly. And that's once the treatment is going on, we need to assess and reassess quite frequently for providing the treatment for the patients. We're here This is the medication reconciliation process to avoid the problem of missing out the medications at the transition points. So how we can do is like to identify and the list of the medications at every point and compare with the previous prescription and also like verify, cross verify, and so that there is no duplication or avoiding of any medications has been done, and document the changes every time, right? So for the other issues the patient have been facing in being complained to the treatment, like we can include the technologies also, like by providing the real-time alerts. Like now many applications have been developed so that we can provide them frequent updates on the time of taking their medications, to provide them the reminders, and also like even to for the follow-up visits also, like we can provide them the visits, and for prescription refilling also it can be provided. And this not necessarily it have to be done by the hospital only, maybe from the pharmacy setup also, like because now our Indian background, Indian setup is like maybe if we are purchasing a medication from one pharmacy means like we frequently go to that pharmacy only, right? So we be a regular customer to that pharmacy. So which means like the pharmacist over there is having more responsibility to ensuring our adherence to the treatment also, right? So if not, we can use the computerized physician orders in the hospital setups, like to avoid any kind of errors, especially the misunderstandings, and also like the CDSS, the clinical decision support systems or the services also can be employed for providing this one. And for in addition to this one, so what we can employ is for the patients who are unable to reach to facility, healthcare facility, what we can do is like here in Malaysia, they follow a practice called as the home medication review, where home medication review it's a process where the healthcare team, they will be visiting the patient's home only. I think in Tamil Nadu we have what to say, we have a policy known as illam tedi some illam tedi some marundagam or
மருத்துவம்
sorry, martuvam, yeah, exactly.
மருத்துவம்
Yeah, it has been employed in Tamil Nadu also, like the pharmacist or even the nurses from um, every hospitals or from the every setup, they just go and they can see. But here, that home medication review, they don't do for all the patients. They just do for a patient who cannot move around, like they cannot be transferred from their home to the hospital. So they will be going, and also like for the patients who are having what to say, the especially the geriatric populations, like they will be conducting the home medication reviews, like not for all the patients. We cannot go for like that because it will be consuming the time of the pharmacist also, and also the healthcare team also, right? But it has been done in other way also, it is okay. But we have a approach at our doorstep, like which means like the persons or any individuals who have a difficulty in going to visit or to see a doctor, maybe can get a use from that person or from the healthcare team member who has been coming to our visits, right? Even my home also, like my mother used to say, like they're coming this time they came, like that. They are getting updated. So it is better. It is one of the better options now which has been available. Where you may ask, like how about the kids, or how about the children of their family members, means like they also have their livelihood and they will be working, and hospitals usually work on the office time majorly, so it will be difficult for them to adjust their time, and sometimes they will be staying away also, like because if I start touching about the socio-economics, means like it will take another hour of session. So what are the problems, like everything, each and everything, like we can discuss about the socio-economics. It will be more interesting. You can if you are having a chance, means like you can read through the socio-economics affecting the drug therapy. We are seeing the uh, physiological changes only, but it is quite interesting, right? So the that home medication review and the medication reconciliation, those are all the process we can do. And in addition, like some people will be having a difficulty in like waiting up the queues, like they don't want to wait in the queues for a long time to get the medications refilled. So what they are doing is like here in Malaysia, what they do is like they have a value added services in the pharmacy setting. Like you inform to the pharmacy before, they will be uh, kept your medications, the prescription refill ready. You just drive through. They have a drive-through counter. You just go, just like how we get a McD or a KFC, drive through, order and get. Just like that, you can drive through into the hospital. No need to get down also. Drive through to the pharmacy counter. You give your number or your token number, whatever it is, they will give you the prescription medications. And there are some limitations, like certain medications only they will be giving. And also if it requires a follow-up, definitely you have to visit the doctor also, right? So this is another setting. And also like by post, they are sending the medications directly from the hospital. Here in Malaysia, the setting is like the government public hospitals, the people will be more accessing to. So they will be communicating, or they will be contacting the public hospitals. They will be sending the medications through post also. So this is some of the methods to ensure that the people who have their difficulty in getting their services or getting their medications refilled, so they can get it in this way also. So this also will enhance the adherence of the geriatric individuals to the treatment, right? So carefully, the members have been selected, and they have been providing this to the treatment for the geriatrics well-being. Okay, so in addition, those are all the problems what I have discussed, and also like how it can be overcome, especially with the drug therapy. And in addition to this one, we need to have just I would like to have a short discussion about this the geriatric assessment also, because I think 2 months back I had another talk. I was discussing about the geriatric assessment, like geriatric care assessment. So we, as a pharmacist, we should make sure, like when we are contacting or communicating or we are interacting with the geriatric people, we should know, we should assess about the functional impairment, whether how they are performing their ADL and IADL, where this really it plays a major role in deciding the therapeutic outcome to be achieved for the patient, right? So if they cannot perform by themselves, you appoint or you suggest an alternative method also. Okay, cognition, what is their cognitive level? Because some people like they cannot accept that they have forgetfulness. They cannot accept, like if you say, if that individual is having a dementia, they may not, if you say like you have dementia means like they may not accept. They try to behave normally in front of us, right? So nobody wants to accept their what is their inconsistencies. So this should not affect or influence the treatment goal. So we can have a communication, because the pharmacist is the first person to interact with any public, as being as a community pharmacist. And also in hospital also, when they come, we can have a separate session, like the counseling session, to know like what is their cognitive levels, like by performing many tests only. That's all the test what you are going to employ over here. It will not take more than 2 minutes time. Just you can know like how their cognitive functioning is, they are good or not also, right? So you can, by doing the test, you can check for the dementia and depression and delirium, and for the gait impairment, because this is more important, more serious, right? So whether they are at risk of falling or not, so it really decides on the treatment goals. So that also we can assess. This no need any interventional methods. Just you employ a small test. So not taking more than 2 minutes. You employ, you identify, so you plan for that patient more precisely, and you alert the patient, like if they are at a risk of falling down, so you can alert the patient like to how to be careful, because no one will be knowing that they will fall down until they fall down, right? So once they fall down, for geriatric especially, that really shatters their life, their lifestyle, their quality of life, and whatever you call it is, like that shatters. Like definitely the therapeutic outcomes will be not be achieved. And also once they've had a first incident of falling down, they have a fearfulness included all the time. They will be having the fearfulness all the time, right? So they will not be having confidence in doing their functional tasks, the ADL and IADL, right? So this happen, it affects this one, and later likewise it is kind of a chain reaction, especially for the geriatric population. And also like for elder abuse is also known as the elder mistreatment, like not necessarily to be the family member, even if they are being appointed by any other member to take care of. So if they are not treating them better, so this also will be affecting the treatment where the patient has been taking for. And I think I have done a research on the elder abuse also. So maybe I don't know whether I have included in this slide or not. So it is also really really needed to be taken care of, right? So it is like a silent killer. Nobody wants to say that they are being mistreated, right? So if the mistreating person is their family member, if their son or daughter or some member the individual is been depending on for their food, for their daily living, so they think like no need to report it, but this not reporting or a poor reporting will leads to the poor adherence also. Okay, and also the medical and medication history to be collected for the patients all the time. So these are all the things like maybe just I outlined only. So this maybe if time permits, or if not time permits, like if we have another opportunity, I will share about like the geriatric care assessment also. It will be quite interesting, like how you do, like no need of any equipments or any instruments, just with a chair, paper, pen, and like that only, and by questioning themselves, you can categorize that individual. We are not diagnosing, but we can know the risk so that we can direct them to the correct treatment, and also we can achieve the better outcome, right? So this is the some of the other studies that we have done, like the sleep quality, which was affecting the geriatric population, where this sleep quality affecting it will be if the sleep is not so good, then definitely that will leads to the depression. Then that if they are depressed, then again it is going to finally it is going to affect on the compliance of the complaints to the treatment only, right? And also the another study, I think this is the recently published, the article is still in press. I think hopefully this month it will be published. So the prevalence of depression among the geriatric population, where the data have shown like majority of the geriatric population, they face depression, right? So, but if you look at the individuals, they looks normal, right? Yeah, their age with their typical syndromes or typical symptoms. But if you are inquiring, they are depressed, right? So, which is not so good as a pharmacist when you are employing something for the patient, right? So this is I think I have shared what I have achieved for. This is the references what I used for my presentations. And if any questions, I would be happy to answer. Over to you, sir.
Thank you, sir. I now invite Mrs. B. Nivetha, Associate Professor, Department of Pharmacy Practice, to moderate the interactive question and answer session. Please.
Happy some of my lecturers are also here in this session. So who are saying hi, thank you. Belated Happy Teachers Day to all my lecturers. I remember Prof. Karpakavalli, my madam, I think so. Sir, does any particular special facility has been provided by Malaysian government for the geriatric patients in assessing the healthcare settings? Yes. For answering, like I think the question is from Dhanushmati, Miss Doctor. So the question is, does any particular special facility has been provided by Malaysian government for the geriatric patients in accessing the healthcare settings? I would say yes. How is like usually here, as I mentioned, all the people who go for the treatment, they will be getting getting treated in the government hospitals only, like in the public hospitals only. Then you can see like the huge crowd which will be waiting for to see the doctor. So for geriatric patients, same like the other counters, they will be having a special counters for the geriatric patients. So they don't need to wait for the normal counter, like together with the normal population. So they have a separate counter. And most importantly, for geriatric population, those who have difficulty in accessing to the hospital go in the terms of like home medication review. That home medication review, it includes not only the pharmacist, it includes the doctor, it includes the nurse. If the physiotherapist is required for that patient's condition, or whoever the healthcare team members is required, all together they go together as a team to the patient, like to their home. They will be going like monthly visit. They will be going to the patients, like accessing is one. And also like if only the refilling is problem, means like they can have the value added services, like they can access drive through. They just drive through, no need to get down also in the hospital. Drive through, just stop at the counter where they have dedicatedly allotted for that one. Give your in prescription, or the according to the appointment, you go there. They will give you the medications. You can take it, and then you can just drive through. And also like if you can write, and you can get it through post also from the hospital, they will be delivering it through the post. And in addition to this one, they have another method, or another process called as the MTAC, Medication Therapy Adherence Clinic. Here in Malaysia, they know shortly known as the MTACs, where for geriatric also they have the geriatric MTACs, where completely they will be seeing. And most importantly, they have a dedicated team for the geriatric population. It's not like if we have a clinical pharmacist in under the cardiovascular departments, or in a cardiology department, means like that cardiology department clinical pharmacist will be taking care of the all the members, no matter whether the geriatric or not like that. But here, a dedicated member for the geriatric populations alone will be there, and also the geriatrician will be there for the patients. And also here, even though I said like they are developing, but the geriatric populations, or the number of geriatricians, slowly only it is increasing. Like the awareness is getting higher, so they are increasing the number of geriatricians one after another. And also like all the members, even the geriatric pharmacist also is being practicing. Considering like in the northern region, we have two main universities, one public university and one private university. I think we have in public university, there is one professor doing the geriatric research. And in I think in the private university, I am the one who is involved in the geriatric research. So it is very limited, but the awareness is getting more and more, so that the facilities is being they don't have any problem. Like all the way, they will be having access for the geriatric individuals. And what is the most common difficulty that you have faced during your routine practice of geriatric care? Most common difficulty is convincing them. Um, Convincing them is really difficult, because especially those who are affected socio-economically, and especially this elder abuse, it comes under the category of the intimate partner violence, where they don't reveal it, but because of that, they don't want to comply with any of the treatment. So basically, it will be the communication only. So other than that, like no, not much difficulty. Once you have built the rapport, as being a pharmacist, we have the counseling skills also, like how good you are communicating with the geriatric individual. So once you establish the rapport, definitely they are going to be your close friends. So before you go, they will be waiting for you till when the next time that person is going to come. So only establishing the communication is the difficulty I faced. But once it is sorted out, then they are most compliant, right? You explain them, they follow strictly. That is one thing. So another question is, do you suggest any special care that can be provided as a regular protocol for the geriatrics for fall prevention? Yes. I believe the next question is, do you suggest any special care that can be provided as a regular protocol to the geriatrics for fall prevention? Regarding the drugs, there is, according to the, just like the BS criteria, we have another category of medications known as the FRIDS, fall risk increasing drugs, FRIDS. So fall risk increasing drugs. So they have categorized the list of medications which will increase the risk for the fall. So if we are prescribing that medication, maybe try to avoid that medication by giving another alternative which don't comes under the category of the FRIDS. Or if it is the only choice of drug to be prescribed for that patient, then maybe then we need to really emphasize more on the patients to walk carefully, and also like to use the walking aids, and also like, because it is that serious, like if they fall down together with their condition, the fracture occurs, and also for that they give another medication. Like it is very, very difficult. I have seen many patients, many individual, not patient, many individuals, they're normal with their comorbidities, they take the medications, but they just fall down. Oh God, that alone is sufficient for their end of their life in just a few months of time. They couldn't cope up, like especially above 70, those who are very frail patients, like frail individuals, like it is very, very difficult. So we need to ensure like they don't fall down. So we identify the risk, and nothing wrong in walking with a walking stick. Nothing wrong. No aesthetic, nothing. Just safety is more important. We need to educate. And frankly, more than the treatment what we provide for the geriatric individuals, like we need to speak more only. We need to communicate more to make them understand. So if you do that, God, they will be very, very compliant to that one. And also like they will be sharing their experience also. Like it's quite different also. Like they will be, but they keep speaking a lot. So we need to allocate a separate time. We cannot say like immediately we cannot cut them off. Sorry, I have another appointment to other member also. We cannot do that one. So it requires some patience also, right? So I think that is one protocol. So okay, so the next question is how to improve ADI monitoring in geriatric patients while at home. Um, this is the medication reconciliation plays a major role. And at home means like we need to encourage, but by creating awareness to the individual, to the geriatric individual, like if they feel or if they face anything all of a sudden, so it have to be immediately communicated. Like so they can having easy access of communication will sort it out. And also like for ADR monitoring, even though it occurs also, then sometimes the poor reporting, same like the other categories, like poor reporting is the same methods we can employ for, madam. And also what we can do is just allowing them to communicate more for us. So they can having contact numbers, so they, if anything happens, means like they just immediately contact us. If they are in hospital, that's a different story. Like we continuously monitor them. But at home, yes, it is a difficult. But usually what will happen is like when people they come for medications, we need to educate them also. Patient counseling, we counsel them like in case anything happens, like approach us immediately. So that can be the only choice, so to avoid any complications. And any other questions? Hope I answered for the questions. If not satisfied with the answers, means like maybe you can I think my email ID is given, so you can write it down, so maybe I'll be happy to answer.
Yes, sir. Thank you, sir. Any
Thank you.
participants having questions?
I have one question, madam. A quite interesting question. Sorry. My area of interest also. So, sir, do you have special facility for reporting elder abuse at Malaysia? We have elder abuse reporting facility. Like it comes under the law sections. Like we need to, there are certain laws will be protecting the individuals. So which requires like including the enforcement agencies like the police, NGOs, and sometimes if it is more critical, then definitely we need to go with the police also. And by the way, like even though we identify the elder abuse, we cannot approach directly. So it have to be through the proper channel only. We need to inform the concerned NGOs and also through the ministry or through them only we need to employ. We cannot directly go to sort it out. That's a difficult situation, because sometimes the elder abuse will happen between the family members. Then it is a difficult one. So every country will be having the law. If not separately as a elder abuse, particularly for an elder abuse, they will be having like a domestic violence act or also the intimate partner violence act. Like it comes under any one of them, right? So every country will be having that one.
Yes, sir. Yes, sir. Thank you, sir.
Thank you, ma'am, for the engaging moderation. It's my privilege to invite Mrs. Aruna, Organizing Secretary, to deliver the vote of thanks.
Good morning, sir. Good morning, everyone.
Madam.
As we come to the conclusion of the insightful and enriching session, it is my honor to deliver the vote of thanks on behalf of the organizing committee. First and foremost, I extend our deepest gratitude to our esteemed chief guest, Mr. Ganesh Pandian, for your inspiring keynote address on geriatric pharmacy medication older adults. Sir, your presentation has been incredibly informative and engaging, offering us new perspective and ideas. A special thanks to our participants and attendees for your active engagement and enthusiasm. Thank you all once again for your invaluable contributions and participation. Have a great day ahead. Thank you.
Thank you.
Thank you, ma'am. We sincerely thank our esteemed speaker, respected faculty members, all participants, and the organizing team for making a meaningful learning experience. We hope the insights shared today will help us better understand the challenges of medication used in the elderly patients and inspire us to contribute more towards safer and more effective geriatric care. The webinar will continue tomorrow, day 5, with more insightful sessions. Wishing you all continued success in your professional journey and have a wonderful day ahead. Thank you. Thank you. Thank you, sir.
Thank you all.